Okay, now we can start now, and it's Shiraz and Raj Pandian and Amanjeet, you can take over now. And Himanja, you can share your screen.
Hello.
Himaja, can you hear us? You're there?
We can't hear anything. Otherwise, Kavya, can you start?
I think she has joined now.
Himaja has come. Yeah.
Yeah, Himanja is. Okay, go ahead.
Start. Start presenting. Share your screen.
Himanja, your audio is not that clear.
Unmute your audio. Okay, start presenting.
We can't hear. We can't hear Himanja. Kavya, can you come in? Himanja?
I think she's trying to connect the audio. The signal probably is not strong enough.
Kavya, can you unmute?
Hello.
Hello, yes. If you have the presentation, you can share so that she can talk. If audio is okay from her side.
समय पश्चात प्रयास करें. The number you have dialed is currently busy. Please try later.
Hello. Hi, Maja Mandalappan అదే కదా. Well, you should accept the request to get promoted as panelist. Accept చేస్తారా? చేసావు. You are in panel now. You should unmute and speak. Screen sharing, can you see the screen share?
Hello. Am I audible?
Increase
Yeah,
the
yeah,
increase the
Please go
audio.
So is it audible now?
Yeah.
I joined through the mobile, sir.
Yeah. You switch off your then only one. Two is
Yes, sir.
open there. Two
Yes, sir. Is
systems
it clear now,
open. Yes. Carry on.
Is it clear now, sir? Can I start?
Yes. Start.
Yes. Good morning, everyone. This is Himja from Jipmer. I'm presenting this case today. 54-year-old male, resident of West Bengal, businessman by occupation, presented with chief complaints of increase in frequency of bowel movements in the past 6 months, tenesmus and painful defecation in the past 4 months, loss of appetite, weight and appetite in the past 4 months. Next slide, please. Patient was apparently well 10 years back when he developed increased frequency of stools with average daily frequency of 8 to 10 times per day, which was small in quantity, associated with mucus and occasionally with blood. No history of pain during defecation or fever. He was evaluated for the same in local clinic and treated with few oral medication, but without any significant symptomatic improvement. Later, patient was evaluated at tertiary center where he underwent colonoscopy, blood and stool analysis. He was started on few oral medications, one of which was tapered and stopped over a few weeks. He was asked to continue other oral medication, following which he had symptomatic relief with decrease in frequency of stools. In the next 8 years, he had episodic flare-up of symptoms with increased frequency of stools once in 1 to 2 years, for which he was treated with oral medication, followed by resolution of symptoms. He was on regular follow-up till COVID pandemic, following which he was lost to follow-up. In 2022, he had an on and off flare of symptoms, for which he had taken medications of which are same drugs with him on his own, following which he had transient improvement in symptoms.
So what are you dealing with this? Before going
So
this.
with the history of chronic history of around 10 years with also history of oral medications which are tapered over a few weeks, it most probably signifies use of steroids in the past, and a chronic history of 10 years could be with blood and mucus in the stools could be due to ulcerative colitis.
So far you have talked about only the past history. This is the present history, I think this slide shows. Okay, read this slide.
Yes, sir. Now the present history. About 6 months back, he again developed increased frequency of stools, which was small quantity, 6 to 8 episodes per day, non-foul smelling, associated with mucus and blood. He also now has painful defecation with frequent urge to defecate. He also developed significant loss of weight of about 15 kg in the 4 months and associated with loss of appetite. No history of fever, no history of any blood transfusions, no history of abdominal pain or abdominal distension, no history of nausea or vomiting, no history of easy fatigability, cough, shortness of breath or jaundice, no history of eye symptoms, joint pains or any skin lesions, no history of perianal discharge or incontinence. For these complaints, patient was evaluated elsewhere and started on oral medications, which was tapered and stopped. He had symptomatic improvement with decrease in frequency of stools to 3 to 4 per day. He underwent colonoscopy, imaging, and few bed investigations, and then referred to tertiary center. The past history is known hypertensive on non-regular medications, no other comorbidities, no history of surgery. He consumes mixed diet and occasional alcoholic, but has stopped 1 year back. And he has regular bowel bladder habit and bladder habits, and sleep is disturbed. Family history is not significant.
Before going to examination, what else
Well,
you
you-
want to know?
Audio in between. Hello.
This is the maximum volume, sir.
Yeah, yeah.
Yes, is it audible?
We
Yes,
are
yes.
losing your audio in between. We can't hear in between.
Yes, sir. I'll try to speak louder, sir. Volume is this is the maximum, sir.
Okay. So, do you feel anything is missed in the
What is it?
history?
No, sir. Treatment he has received regularly. All the resolution of symptoms, everything is clearly mentioned in the treatment. And in view of inflammatory bowel disease, the extra intestinal manifestations are also mentioned in the history.
Go to the previous
However,
slide.
because of significant weight loss, there can be a possibility of malignancy, and the history of distant metastasis is not given. Like chest pain or bony pain is not given.
So, why there is no history of jaundice is there? How will you correlate? Why you want to ask
It
that
is-
question?
In case of ulcerative colitis, there is a chance of patients having primary sclerosing cholangitis, where they can present with jaundice, sometimes even before the presentation of ulcerative colitis. So,
Okay. So far, there was no previous history of any surgery, any intervention. So, what
No,
does
sir.
that indicates to you?
The disease is well controlled with medications. Did not have any severe flare-ups.
Okay.
Diagnosis was probably accurate.
Okay.
Himaja,
weight-
sorry, I missed in between. I got locked out. I have one small suggestion. When you present a case like which has a chronic history, because you confuse the moderators, you presented cheap complaints from 6 months duration, and then you went 10 years back when you described the history of present illness. There are two ways to present a history. I just emphasize on it. If you have a short cases, which is a very short history, few months, 5 months, 6 months, you can present it the way you want it. But if you have a chronic history, like a chronic liver disease or a chronic kidney disease or a condition like this, where there's a history which goes back to 10 years, you still can present in the way you wanted to present chief complaints and elaborate on the chief complaints first and then go to the past history. Otherwise, you start from the beginning. You start the 10 years back, what happened, and now what is the present aggravating symptoms. When you mix these two formats, you get the audience confused. Another suggestion in the history part I have is that when you are presenting a history, it shouldn't be like a robot presenting a history. You are not giving any pauses to the very significant parts of the history. You are just running and reading through without giving an emphasis on certain important factors, which are very important as far as the patient complaints are concerned, and as far as your information is given to the panelists or the moderators. So give a pause in between. Just relax. Don't worry. Don't rush through the history. You are a bit anxious, probably. Just it's a breakfast discussion, basically. You are giving us an information which we need to decipher. We need to cut short the irrelevant parts of the history and concentrate on very important aspects of the history. Okay, that's a small
Yes.
suggestion. So coming
Yes, sir, I'm sorry.
to, I missed in between. Yeah, Dr. I think Raj Pandian was asking something. Yeah, please go ahead.
So, whatever you want, they have given in the history, elaborate history is there. As I mentioned before, it's the same thing. Probably this slide should have come before the previous slide, so that it have a continuation of present illness, then it will go to the past history. Anyway, the history wise itself, it is obvious is there. Obvious is the inflammatory bowel disease. Anything else you are thinking in your mind?
No, sir. It is a case of inflammatory bowel disease, but the recent attack could be an acute flare-up or an development of malignancy on the background of inflammatory bowel disease. Either of them can be possible with this history.
Anything else
So
you
what do you
want to
think?
get from the history? Any other important information from the history as far as this IBD is concerned, as his follow-up is concerned?
So
Anything
the
else
medication-
where you're missing
med-
something?
So the medication history and the response to the medication is one which is important, that is given in the history, sir.
Yeah, anything
And,
else you feel like is missing? Or you want to get more information? Say, for example, colonoscopies, was he getting a screening colonoscopy done in last 10 years? What was the frequency of colonoscopy, isn't it? IBD
Yes, sir.
people have a definite, we have a protocol for giving them a screening colonoscopies or surveillance colonoscopy to see whether they are developing any such kind of lesions, right?
Yes, sir. But this
think that's
patient has
what
a disease, and so he may not have underwent a colonoscopy, and recently has
presuming
crossed 8 years.
Yeah, you're presuming you
So-
should have asked that we want
No,
that
it
part
should
of
have.
information in the history, right?
Yes.
Since we're discussing, when should the screening colonoscopy be, Himanshu? In a patient
sir.
of chronic ulcerative colitis, when will you do a screening colonoscopy?
So the recommendation is to start after 8 years in a case of pancolitis, and after 12 years in a case of left-sided colitis, to start annually screening
Which
of
recommendation? Which recommendation are you talking about? It's specifically 8 years and 12 years?
any disease which present 8 to 10 years is at risk of developing malignancy. So
Okay. So
annual
what is the risk of overall risk of developing malignancy in a case of
is,
colitis?
1% up to, it is 1% up to 10 years and around 10% to 20 years.
Yes,
Only
around-
1% in 10 years, are you sure? That's wrong. For one
So
person,
up
why
to
you want
10
to
years.
know? See, what you are told is they see of following the IBD, these recommendations only for the Western and USA, not in India. Okay. But as you said, after 8 years, the incidence of malignancy, IBD, is slowly increasing, starting from 2.5%. As you said, the patient who is having more than 20 years, so they have like more than 8.5% of 8.5 to 10% chance. But meanwhile, you may have to take a biopsy. If there is any low-grade dysplasia is there, that is also the indication for intervention, okay? Or Dalm lesion, okay? So you have extensive pseudo polyp, you take one of the polyp and say it's a low-grade dysplasia, there is a high chance it can go. So if you find that, then the surveillance comes, so you may have to take every year you have to do. That is for the normal person, okay? Those who are having with the remission. So those who are in the remission, you can wait, okay? So if you wait for 8 years, but depending upon each patient, okay, how they respond for the medical treatment. But as you said, you are correct. Surveillance colonoscopy in IBD starts after 8 years, they think. So this was given, but practically if you see, what we see in the patient, those who are having acute and they have a flare, then have a remission, you should keep follow up probably every year, you have to keep watching.
Yes.
Okay, so just for the audience, summarize when will you get a screening colonoscopy and what should be the interval?
Yearly colonoscopy after a period of 8 years with
After
the
10 years, 8 to 10 years, we should repeat a colonoscopy as per guideline. And how frequency, what should be the frequency later on? Are there any risk factor for developing colorectal cancer? Are there any high risk group where you will recommend colonoscopy earlier?
Yes, sir. If the extent of disease is pancolitis and compared to the left side colitis, and if they have a lesions, any polyps or lesions or mass or already diagnosed dysplasia in the previous biopsies.
And there is
So
a
the
family history
frequency,
also.
sorry, yes, the hemorrhage frequency is 2 to 5 years. So 2 years in a high risk group. So there are specific high risk group, intermediate group, and a low risk group. So based on various factors like history of any concomitant primary sclerosing cholangitis. So they are at more prone to developing malignancy. Extensive colitis, family history of colorectal cancer, especially if it is less than 50 years of age, and possibly male gender. So these are 4 or 5 criteria on which there are guidelines. They are recommended intermediate, low group, and high risk group. So they recommend screening colonoscopy 2 to 5 yearly, depending on the risk associated. Okay, just read about that in detail.
Yes, sir.
There's specific guidelines on that. How to do
Yes,
screening colonoscopy, what all techniques are available to increase the yield. So this is the full mark question for DNB.
Yes, sir.
Okay, I
I'll
think
go, sir.
we can go ahead, yes.
Okay, go ahead.
On examination, patient is conscious, cooperative, and well-oriented. He is thin built and poorly nourished. BMI is 17.64, and he has a performance status 0. Breath holding time is 25 seconds. Pulse rate is 88 per minute. Blood pressure is 130 by 70 mmHg. Respiratory rate is 18 per minute. He is febrile. He has pallor and bilateral pitting pedal edema. No cyanosis, icterus, clumping, or generalized lymphadenopathy. No palpable left supraclavicular lymph nodes. No obvious signs of dehydration. No redness or watering of eyes. Peripheral joints are unremarkable on examination. On per abdominal examination, on inspection, abdomen is flat, umbilicus is central and inverted. All quadrants are moving equally with respiration. No sinuses, engorged veins, pulsations, or peristalsis. Hernial orifice has no visible cough impulse. No renal angle fullness. Palpation it is soft and non-tender. No, spleen and liver are non-palpable. No other palpable lump. No palpable cough impulse over hernial sites. Liver span is 13 centimeter in the right midclavicular line, and flanks are tympanic. Normal bowel sounds are heard on auscultation. On a digital Excel examination, an external opening is noted at 7 o'clock, which is 0.5 centimeter from anal verge, with no active discharge, erythema, or significant induration noted around. And a circumferential hard growth with ulceration and luminal narrowing, just admitting the index finger, is noted with a lower border at 3 centimeter from anal verge at 6 o'clock. It is mobile and does not bleed on touch, and upper border could not be reached. The internal opening is noted at 6 o'clock position, which is 3 centimeter from the anal verge with an induration around. The normal resting and squeeze tone of anal tone is noted. On examination of inguinal lesion, no significant lymphadenopathy is seen, and examination of eye, skin, and joints is normal. The respiratory system, CVS, and CNS systems are essentially normal. So
what is going on in mind after examining the patient?
This patient is having a good performance status, but poor nutritional status, and he is having
a good performance status. But you said there is a pedal edema and anemia, isn't it? Obviously, you said pallor and bilateral pedal edema. Patient is, you said lethargic. Okay. Breath holding, this is 25, that's good, okay. But you said bilateral pedal edema is there, anemia is there. What is going in your mind? Patient is anemic and?
His nutrition is poor because of
hypoproteinemia. Okay.
Yes.
So probably he's having acute flare with hypoproteinemia because of diarrhea, loose stools with the mucus and blood. So he's losing blood as well as protein. Okay. So malnutrition is there. Apart from what we have what is the finding?
He has a rectal luminal narrowing due to hard growth in starting from 3 centimeter from anal verge, admitting only index.
Slide. So the perirectal finding. Okay. So what is going in your mind?
So patient is having a circumferential hard growth with a luminal narrowing, which could be malignancy in the lower rectum starting at 3 centimeter from the anal verge, and having a luminal narrowing, and he's also having a fistula which is probably a simple perianal fistula, because the external opening is only 0.2 centimeter from anal verge, and it is opening at 6 o'clock posteriorly as
Then do you think this
normal.
is a simple fistula or the digital examination? Do you think this is correct?
What is your concern? Yeah, what is your main concern?
Is the malignancy of the rectum.
Okay.
Somewhere
Is the
in
inter-
IBD you examine, there is a fistula.
IBD with fistula, it could be Crohn's most probably, sir. But still, with the history he never had any obstruction or any perianal discharge previously. So I would still like to think of ulcerative colitis with the rare possibility of perianal fistula.
Now, do you think this digital rectal examination has given you an exact details of the fistula, that internal opening noted at 6 o'clock position? Do you think you can really get a this is
I
this is
think,
not a
do you
pro-
think
this,
this,
this is a
do you think
proctoscopy
that,
examination plus or
do you think
sorry,
the
say again?
digital rectal examination give this exact finding, or there may be something wrong? So he
Is it a
said there is a
proctoscopy
3
also, or
centimeter.
Yes,
So
it
one
is
is
a
the lesion and the internal opening are starting at the same level. So the induration could be because of the lesion rather than the opening. So the finding
no,
can be.
Himaja, I'm just asking you a simple question. Is this a digital rectal examination / proctoscopy combined together, and or is it just a rectal examination, which the findings have been described?
It is a cervical examination. It is
So do
3
you,
centimeter.
okay, hold on. In your practice of fistulas, which is a general surgery topic, how many times you have been able to label and document a fistular internal opening on your digital rectal examination? Do you think that is okay?
Yes, sir. It is difficult to document, sir. However, this patient has induration and it is only 3 centimeter from anal verge. So it can be felt with digital examination alone also. However, proctoscopy is definitely
With a
mandate.
tumor with a tumor inside, and if you look at the tumor description, you are saying that the tumor is noted at 6 o'clock position, ending 3 centimeter. That's exactly where you are pointing the internal opening of the fistula. I would
So
never
that is
write
not
digital
internal opening.
examination.
What they are palpating is only that ulceration of the heart growth. They think that is internal
Yes,
opening.
maybe.
So that third row,
Isn't it?
the third sentence should be removed. All others should okay. Okay. And 3 centimeter above the anal verge, it is not a, if you feel it is an internal opening, it is not a simple fistula. What he was having there, since there is no any discharge, there may be small external sinus with 0.5 centimeter from the anal verge. No active discharge, that is okay. Probably there is no any internal opening for this patient. Or what they are palpating is only the ulceration of the growth, which is circumferential, not allowing the intestine. Definitely they can't palpate the internal opening in this case.
Yes.
Okay.
And
So
immediately on this, you change your diagnosis from ulcerative colitis to Crohn's disease. You just flip that it may be Crohn's disease. You may still have ulcerative colitis, and your patient may still have a fistula, isn't it? It doesn't mean
Yes.
that the fistula happens only in Crohn's disease. A normal person also can have a fistula. And there was no history suggestive of a fistula, a perianal fistula in the past. So don't flip your things very rapidly.
So okay. On the
Think
other
that
hand, what is
finding can be wrong.
the perennial findings of Crohn's disease? If you feel it is, tell me how it presents, and when will you think while doing a PR? Okay, this will be a Crohn's disease.
They will be having multiple fistulous openings, or at least anal skin tags suggestive of healed ulcers, chronic fissures, healed and chronic fissures.
Multiple fissures in abnormal areas. Usually, in a male, you will have a 6 o'clock. In female, you have a 12 o'clock. So other than 6 and 11 or 12 o'clock, if you have a multiple other area of fissures, you should think of Crohn's disease. Okay, if you're in a patient with the IBD background. Okay, you can have multiple fissures, multiple sinus opening or multiple fistula opening also. Okay, in unusual position. Then only you keep it. Okay. So come to a conclusion now. History examination, what is going in your mind?
This case is a case of ulcerative colitis with a carcinoma of lower rectum with the patient having poor nutritional status.
With the acute flare or not? That's what we want to ask. You said
Sir,
it is now 6 to 9 times is passing motion with the tenuous mucus and blood.
After examination with
Patient is
the
anemia and hypoproteinemia.
yes, the history and general examination is pointing towards an acute flare-up. However, patient is also having a malignant lesion, which is also could be reason for the weight loss
And
and
the patient has taken some medication and it has relieved of symptoms as well, isn't it?
yes, relief of medication.
So patient has presented with the acute flare. On examination, we have found that there could be a malignancy as well. Okay, so this should be your diagnosis. Do you have anything else? Any other differential diagnosis going in your mind in this case?
Only the one more possibility is the Crohn's colitis, sir, which can also present in a similar way. However, there is no other a significant perianal disease or the small bowel disease, so it is less likely. But there is
So
still chance of Crohn's
why you
colitis.
want to differentiate ulcerative colitis and Crohn's? If you ask medical fellows, they always say it is IBD. Only surgeons we want to very bother about ulcerative colitis and Crohn's. Am I correct or not?
Yes.
As a surgeon, we should know we want to differentiate Crohn's and ulcerative colitis. Very, very important because we are surgeons, we want to deal. So we deal the Crohn's disease differently and ulcerative colitis differently. Whereas medical fellow, they for only IBD. So what is going on in mind? If it is Crohn's, what will you do? If it is ulcerative, what will you do in this case? Your approach will be different from the investigation aspect or same?
Yes, a clinical suspicion is of malignancy, so he'll require surgery definitely, wherein ileal pouch may be required in this patient. So I would like to rule out the Crohn's disease before
hold on. You are planning ileal pouch in this patient? Tumor is starting at 3 cm from anal verge.
Sir, not right away, sir, because if it proves to be malignancy, I will go for the neoadjuvant chemoradiotherapy. Following that, I'll reassess.
Even after therapy. So tumor starting at 3 cm from anal verge.
Yes, it may be less likely to go away from the sphincter, but still there is with
Why not? You can't do only after neoadjuvant you will see the response. Then you will assess the sphincter function. Then we'll decide you have to tell for that question.
Okay. Himanshu, I just want to add, from a surgeon perspective, I have two concerns, as Dr. Raj Pandian was asking you. I have important concerns whether there is a flare plus there is a tumor, or whether the symptoms were spurious because of the presence of tumor. So whether there's an inflammatory component also, or it is tumor alone, may have some bearing on it, and probably clinically we may have two factors to find out whether there's an additional flare. That is one, you do an inflammatory markers, and we will be doing a colonoscopy on him to see the extent of disease and the rest of the colon, and they may find active colitis in other parts. That is what clinically we will have an impression whether there is a flare plus there is only the tumor. Okay, that it hasn't bearing because we may have to give steroids on a patient with a tumor and all is important. The second part in this entire discussion is the assessment of the distance between the anorectal junction or anal verge to the tumor is very subjective in terms of different surgeons doing 3 cm, 4 cm. I always keep a margin of around 2 cm plus minus in this all assessment. So what we are looking at, whether there is a chance of a future reconstructive surgery, or we're going ahead with a different pathway, that all we'll discuss in the treatment part. I would request if we can go on, because we're almost past 30 minutes.
Yeah. Start. So how will you investigate this patient?
Yeah,
investigation. Yeah, already we have 35 minutes.
This patient recently had on colonoscopy and
no. What investigation you want to ask? Tell me first. This is the patient. How will you investigate? General and specific investigation.
To proceed further, I want a colonoscopy.
Patient is in front of you. No. patient in front part is sitting in front of you. You want to go for colonoscopy before that. You won't ask any other investigation. Patient already anemic and malnourished. He is in bilateral period edema. We don't know his cardiac status. Directly send the patient for colonoscopy for preparation. This is the wrong way of answering. You want to assess the patient condition,
You
whether
think like a surgeon. You think like a surgeon.
will be there,
You're saying-
hypoproteinemia will
Yeah.
be there, anemia is there. You want to correct that. You don't want to subject the patient directly for colonoscopy, isn't it?
I am planning for a colonoscopy, but I'll do a
Planning
colonoscopy
for
only after.
colonoscopy, yes. In possible, while doing PR itself, proctoscopy, I will take a biopsy, you should tell. Okay. So
Yes,
you
for
do a
the
basic
malignancy
investigation. Tell me, so basic investigation, you are looking for anemia and hypoproteinemia, dyslipidemia. So you like to see that condition, and you have to improve that condition before planning for any colonoscopy.
Yes.
So what do you want to
Biopsy
see?
for the
Basic.
malignancy and
Basic.
colonoscopy for to see the extent of disease and resolution of disease, the
That
recent
is later on,
treatment.
Himanshu. Just start with the
Later.
blood investigation
Start with the
first.
blood investigation, yes.
Yes, sir. I'll want to see the. His hemoglobin is 8.5 with total leukocyte count of 9,300 and platelets of 5,56,000.
Okay.
He's having, and there's a urea is 23 and creatinine of 0.76, and electrolytes are normal with sodium of 131 and potassium 4.2 and chloride of 101.
Okay.
As LFT is normal, and ALP is also normal 173, and albumin is 2.7, which is a lower side, and globulin is 3.1, and INR is 1.
So you expected hypoalbuminemia and anemia, both are there, but there is no dysalkylемia, there is no thrombocytopenia. That means there is no acute flare in this patient. Probably are responded to the medical treatment. Okay.
Yes.
Next, what else you want to ask? So your basic investigation is anemia and hypoproteinemia. What else you want to know? Next.
I would do an CEA also for him as an because I'm suspecting a malignancy.
Okay, okay. You want, as he was asking, acute flare, any other investigation markers you want to know whether the patient is having acute or not, apart from
Fecal
CEA?
calprotectin. Fecal calprotectin.
Calprotectin is not a sign for acute. Okay, so what is the important things? High sensor CRP and procals you can see. Patient is having in a acute ulcerative colitis or not, severe acute condition. Okay. CRP is okay.
8.
Okay.
It's 8, so slightly is on a higher side, and probably he has
More than
taken
5,
some steroids.
Yes, yes.
He has taken some steroids also, so there might have been an element of flare also. So let us see the colonoscopy report if we have.
Oh, CA is
CA
increased.
is
So
14.
what is going in your mind? If you CA is 14.6.
Could be a locally advanced tumor or also in a disseminated tumors.
Okay.
CA is going to tell you the condition, the stage of the disease. How is the initial CA important?
The
You
initial
said locally
CEA,
advanced. You said locally advanced or advanced disease based on CA of 14.6.
the 14.6 is significant raise in CEA. It could be just a local disease, or any CEA greater than 10 can also is an sign of
Metastatic disease.
So you will
Which
think of doing a PET CT before going for surgery. That's what you want. Okay. So increase in CEA, give the increased volume of the tumor or distal metastasis. Okay. So what else you want to do next?
But
You have
this
CEA,
increase in CA is not defined actually. What Dr. Amanjeet is trying to say is that, like, you know, we don't know what is increased. 200, 300, yes, definitely increased. 10, 20, 14, it's like, you know, in that gray zone area. So we will not be biased with the CA alone. Obviously.
yes.
Yeah, if it is 300, 400, we know that we will try to look for any. It is not a logarithmic correlation. There is no direct proportionate, like, you know, so we can't put a level. Probably I'm not aware of any level where CA can tell us whether it is metastatic or not. So
Yes, Dr.
we
Shiraz,
should avoid
nobody is aware of.
these kind of.
that
Yeah, these
helps
words
us
like in the
to
examination.
for
yeah.
the other investigation. That's all.
Yeah, that's
Okay, next
what next you want
investigation.
to do?
So you want to know the colonoscopy and biopsy?
Colonoscopy.
Also
Okay.
proliferate to growth in the at 4 centimeter from anal verge with luminal narrowing, scope not negotiated beyond. Rest of the ball could not be seen.
So what else you want to say? Scope would not be negotiated as a surgeon because you are planning for what is important as previously the faculty was discussing.
The
Two things you want to
extent
know in
of
this
the
patient.
ulcerative colitis and also the synchronous
No,
lesions in the other parts.
No, that is this way you can't go beyond this. No. 4 centimeters from anal verge, whether it's anal verge, you want to know from the dentate line, how far it is from the dentate line. That will assess whether you can have a pouch or not before going for surgery after neoadjuvant CTAT. Okay. And another thing, the function of the sphincter. So clinically as well as, if possible, well, manometry. These are the two things you should assess before while you are doing a perirectal examination as well as while doing the scopy. Colonoscopy or sigmoidoscopy. These two is very, very important, particularly in this case, if it is 4 centimeters from the anal verge, definitely if it is more than 3 centimeters from the dentate line, and the sphincter is good, this fellow is a young fellow, a young male, so we can offer if he have a good, good response after neoadjuvant CTAT. Okay, so what else?
So one
Biopsy came as?
Himaja,
Okay.
sorry, one small comment I want to make is, will you prepare this patient for colonoscopy? Will you give bowel preparation
Yeah.
for this patient?
So on the distal rectal examination, index finger was the tumor was admitting the index finger. Maybe based on that, I would prepare the bowel. So he does not have any signs of obstruction or abdominal distension. But in the colonoscopy, they are not able to pass the scopy. Probably a pediatric scope can pass through the lesion.
Okay, I would be really concerned because this patient has been having loose motions. He's throwing out everything. He's on a low diet. Yes, I agree that he is not clinically obstructed. We may try, but sometimes it can become very difficult to manage these patients. They go into a abdominal distension.
What he is telling
he's
is
already distrusted,
Yes.
He's already distrusted. If you can see from the history, which you said one part, that his sleep is disturbed, which you didn't emphasize much. So his quality of life is extremely poor at the moment. He has been suffering for the last 2-3 months. I'm sure he's hyperproteinemic. He's not taking adequate diet. And sometimes in these patients, we would like to see an imaging before actually go for a colonoscopy to get an assessment whether this is impending something which we sometimes may not, get an idea clinically.
Yeah.
And second thing, I would also like to emphasize that if you feel a growth which is quite low in your rectum, and we can see a hard growth, a rectal examination is not an examination which anyone wants to be done on himself or herself. So it's a very embarrassing procedure. Don't try to see whether I can go above the tumor. Those are written in our surgical orthodox books. That's a very long, old books. We don't want to get that kind of information on a rectal examination, giving a discomfort to the patient. Yeah. Even proctoscopy becomes very, very difficult, sometimes very painful. They bleed. We should just get an assessment where the tumor is or length is. The second comment about is, if your colonoscopy is saying 4 centimeter, your hand is saying 3 centimeter, which one will you believe in?
The
the length
examination is more sensitive
more
and more
important.
related.
Okay, next. Okay, that's it. Next, what do you want next?
So since the colonoscopy cannot see the rest of the colon, one thing I would like to see the previous documents to confirm diagnosis of ulcerative colitis, and then cross-section imaging with the CECT chest and abdomen for this patient to see the other lesions of the colon.
So yes, previous colonoscopy, if it is normal or pan colitis or left-sided colitis, that you can take in mind. And you like to know the biopsy report. And as you said, you would like to do what radiology investigation you want to do in this case?
So, CECT chest and abdomen.
See, already, okay. But because CA is increased, directly we can do PET-CT in this case instead of again doing twice. Okay. So let us see the biopsy report.
Only CT scan, you don't want to do anything, CT or PET, that's all you want to do in terms of cross-sectional imaging for a rectal
Anything
growth?
No,
else
sir.
you are,
First,
yeah,
I'd
yeah.
like to see the
Sorry,
for the
your
local
voice is
stage.
breaking.
The local staging, yes, important.
First, I'll try, want to rule out the other distant metastasis and also other lesions in the colon, sir. After that, I would like to come to the local staging of the rectal lesion.
By,
What is that?
by doing what?
Sir,
What investigation you do for the local staging?
the current CT.
What is that?
Sorry? How will you do a local staging?
With an MRI pelvis.
Yes.
Yeah, say
Okay.
that we'll do an MRI pelvis with a
Yes.
CT scan, abdomen
Yes.
contrast, or a PET CT
Okay.
scan, or a
So
chest
let
CT
us see
with
the
the
CT scan
contrast.
first, then MRI. Biopsy, okay. Poorly defined mucin secreting. So mucin secrete not useful for,
PET CT may not
Yes.
show up the lesion.
okay. So do the CT scan. Let us see the CT scan finding.
This is a plain CT of chest and abdomen. There is no free fluid in the abdomen. The bowel loops appears normal. No abdominal dilatation of or thickening of bowel loops seen.
Can you see the cecum here? Can you see the cecum?
This colon looks normal.
Can you see the cecum on the right side?
Cecum appears dilated.
Yeah, so why are you saying? Why do you think cecum is dilated and rest of the bowel is normal? Is it okay?
The maximum dilatation will be seen in cecum in a case of obstructed disease. However, the dilatation, the descending colon also appears to be dilated in this case. It could be also because of the obstructing lesion and also the negative contrast given the rectal enema or something.
Yeah, that's what I was telling you. We should be very careful in a obstruction growth.
Yes.
Imaging sometimes is very important. I mean, when you also give an order for imaging, we must be very careful in telling the residents, the radiologists, that please do not give a contrast, negative or a oral positive contrast without seeing the plain one. That's the information you
Yes.
want. In this patient, why is the cecum? It's called a closed loop obstruction. Your ileocecal valve is competent. The patient is developing a closed loop obstruction. Now, clinically, you may be okay at the moment, but if you give him a contrast, it may worsen the situation. Even the sigmoidoscopy or a colonoscopy, they should be very careful not to inject too much of air inside and cause a perforation of the bowel, and then there'll be a disaster. So those are the two things: the giving a bowel preparation order, giving a CT scan order, and communicating with your endocrinologist, with your endoscopist to be very careful in insufflating. Sometimes they just do a sigmoidoscopy without air, without pushing in any air inside, if they feel that it is non-negotiable. So these are very important things. Simple procedures can just go out of, if you perforate it to in a patient like this, we're almost done. And if you see the parietal muscles, it looks like he's really malnourished. There's hardly any muscles, seen. Okay. And then we look at the calcification. Some of the patients have a very bad calcification. So in plain, you get a plethora of information on a plain CT, looking at the bowel distensions, calcification, vessels, particularly in, elderly patients or diabetic patients. Okay.
Yes, sir.
Yeah, good. Next, what
Calcification.
contrast can we have? Contrast.
This is a contrast enhanced CT showing no obvious lesions in the liver, no IHBRT, no periportal lymph node seen. The vessels appear normal, the mesenteric vessels appear normal, and there is no focal thickening in the small bowel. The large bowel also is uniformly distended, however, no thickening of the wall is seen.
No, you can see this thickening, no? Can you see the thickening in the
Thickening
rectum?
is starting at the rectosigmoid junction and it is
Yeah.
extending with the
It's a
circumferential
long
thickening with
segment thickening.
maintained
Yeah.
fat planes and few mesorectal lymph nodes are seen. Our lower extent is reaching almost near to the anal verge. Distance cannot be seen.
So you can see a hyper
ma-
mucosa, a long segment thickening in the rectum with some
Yes, sir.
mesenteric stranding also seen. Multiple nodes are seen in that area, right?
Yes, sir.
Okay. Can we go a bit up, please? Who is scrolling the CT? Can we see a little bit proximal parts of the colon? Yeah, we are seeing the
The region
sigmoid now.
starting at the rectosigmoid junction. Sigmoid up.
There is some mucosal enhancement
Enhancement in the
around
sigmoid region.
around the cecum, around the mucosa is a bit more hyperemic, isn't it? Yeah.
Yes,
okay.
sir.
Yeah. And the liver, can you see the liver and spleen? Did you see spleen was a bit more than normally enlarged? Can we go upper part, please?
I did not see the spleen.
Spleen is a little bigger, isn't it?
Yes, I did.
And how does the liver look like? Can we see the liver features, please? Looks a bit
Big
wavy
corded flow.
margins, but yeah, fissure is a bit
Hypertrophy of
broad,
left
okay.
lobe is seen with the irregular margins.
Yeah, okay.
So if
But
spleen
his
is enlarged, what is
platelets
going
were
in
high,
your
isn't
mind?
it?
The platelet is normal. So if in case a splenomegaly is there, what is going in your mind? But liver, you feel liver is okay at this case.
It's a bit wavy, yeah. Not frankly cirrhotic, yeah.
So you should keep in mind maybe
Total
you are dealing with some early cirrhosis with the portal hypertension. Okay.
Yes.
So now you have a
Okay.
non-metastatic probable mucin secreting adenocarcinoma of the rectum in the background of ulcerative colitis with the flare. So
Yes.
how will you proceed next? You want to know what is happening in the
in the pelvis, I want to see an MRI pelvis to know the
MRI. Okay, we'll see the MRI
local-
pelvis now. Show the MRI pelvis. Okay, now you see. So what are the things you want to know in the MRI pelvis? Tell me. If you ask for MRI pelvis, the radiologist has to give what?
Yes,
How will
extent
you?
of
How will how will you give the MRI report? How will you read?
I would like
How
to
will
know
you
the
ask
extent of lesion both longitudinally from the lowest from distance from the anal verge and also the total length of thickening and the proximal extent of the disease and also the circumferential involvement of the thickening. Is it circumferential or is it to an patent of the rectum, and also the involvement of mesorectal fascia, and to know the presence of mesorectal nodes, and CRM, is the CRM threatened or not, and the fat planes is maintained with the adjacent structures, with the anterior structures, mainly the prostate and the bladder.
Simply,
And
you
in
have
this
to tell. You
particular-
want to know
in
the
this-
T stage, N stage, then another two important points is there.
The extravascular neural invasion and
Yeah,
so
EMVA, there CRM a positive or negative. EMVA. Another thing is
Now, in
any
this particular
tumor
patient,
deposits are there. Okay, that is very, very important in MRI pelvis. So these are the 4-5 things which will differentiate. Okay.
Himaja, in this patient, you have a concern. You have somebody documenting a fistula, external fistula, right?
yes,
You
sir.
need to know.
Yes.
MRI is a gold
Yes.
standard for delineating the tracts of a fistula. So I will be very concerned to see whether MRI has picked up a fistula, right?
Yes.
Okay, good.
Yes, sir.
Can you read the MRI? What are the sequences? Not go much into details. I think we're running out of time now. If we can quickly go through this.
Yeah,
Compression
another 5-10
thickening
minutes.
the sigmoid junction with perirectal fat standing and enlarged mesorectal lymph nodes are seen. However, the CRM looks uninvolved.
There's a stranding scene right up to the CRM, isn't it? I mean, there's a
It's
stranding
fat standing
scene.
above,
Not, yeah, just short of the CRM. Multiple nodes, long segment growth, Wait, can you go down a bit?
Fistula is
Can you see fistula?
I'm not able to appreciate the fistulas.
So there is no obvious fistula there.
Yes, sir.
Okay, let
Which
us see
sequence is
the
this? Which sequence is this?
T-tone.
why do you say that?
Bladder is
Okay, we'll see the MRI report, please. So you want to know the MRI staging of the disease so that we can correlate after the surgery. See, always you should have
yes.
a MRI staging. Okay.
Long segment, 8.5 centimeter length of mild to moderate semi-annular mural thickening involving mid-distal rectum and anal canal is spared. Maximum thickness along the right lateral wall is 12 mm. Luminal narrowing is noted. No evidence of any significant obstruction. Prominent mesorectal fat standing. Extramural extension of lesion between 7 and 8 o'clock position by approximate 6 mm. Multiple small volume enlarged lymph nodes are seen at the mesorectal, mesenteric. Large mesorectal lymph nodes at a 4 o'clock position measure 6.5 mm in short axis. Largest mesenteric lymph node measuring 8.5 mm in short axis. The involved lymph node shows hyperintense signal on high B value diffusion weighted imaging and corresponding intermediate to low ADC values. There is a 7 mm ill-defined mild T2 diffusion weighted image hyperintense nodule in right mesorectal fat. It shows irregular speculated margins, suspicious tumor deposit. EMVI is negative and the CRM is clear. Closest distance between enlarged mesorectal nodes at 3 o'clock position and mesorectal fascia measures 4 mm. Urinary bladder is partially distended, posterior and basically unremarkable. Few small volume enlarged pelvic side wall lymph nodes are seen. And distal edge of lesion is approximately 5 centimeter from anal wedge.
So distal edge is 5 centimeter from anal wedge. Okay. So now you have a complete diagnosis, you have complete workup. So what next? What will you going to do for this patient? So
this patient has an T3N2 disease, sir. He has a multiple lymph nodes, especially on the mesenteric lymph node, mesorectal lymph nodes, and CRM is preserved.
you are breaking, your voice is breaking.
Chemo
Hello?
radiation. I would
No.
like to give a long course chemo radiation for him, and
This
during the
patient is
period of
affected
No,
more.
whenever the examiner asks, you said, I will subject the patient for tumor board discussion.
Yes.
That is the
MDT
answer we
Yes.
expect. So MDT. So this is the case, you have to have MDT along with the medical gastroenterologist,
Yes.
surgeon, and a medical oncologist, radiotherapist, and etc. radiologist. So this is the answer
Yes.
we expect. Okay, then you tell, so what the discussion is going on. Okay.
Yes.
So this is the answer. So what will you do in this case? So you have MDT tumor board discussion and you will discuss pros and cons for this patient. So you want to do a
First thing about the disease activity, because a patient will be going for
everything we
requires
have done. We are discussing the now treatment aspect.
Yes, sir. So,
Tell me the type. Tell me what treatment you want to give.
for the malignancy, it requires a neoadjuvant therapy, sir. So
Yeah,
for
you
the
said
period
what
of
neoadjuvant therapy?
Neoadjuvant chemoradiotherapy followed by chemotherapy. I would like to give a total neoadjuvant therapy in this patient, sir.
Why you want to give total
And-
neoadjuvant therapy?
Because
Do you
of
think-
his inflammatory bowel disease status, the post-operative complications are expected to be more than the normal patients. The patient may not be able to receive the adjuvant therapy if it is not received preoperatively. And
So if
And,
the patient is not a it's the same patient without IBD, same patient your treatment is differ or same?
so even in the patients without IBD, TNT can be considered. However, both of them can be considered. Sir. With the recent evidence, TNT is favorable than the traditional post-adjuvant chemotherapy.
Okay, you're giving a neoadjuvant chemotherapy to this patient. Now this patient is in you decided in the tumor board that we'll go with the plan of a neoadjuvant protocol for him. Now this patient comes back from into a clinic, and you have taken a decision in the tumor board that we are going to do this. And now this patient is in front of you. Please explain me as the patient what your concerns are and how are you going to address my concerns? What are you going to tell me?
So one is the disease activity. The patient should be relapse free throughout the period of neoadjuvant therapy, so that he does not have any interruptions in the neoadjuvant therapy. For that, I would like to confirm the current severity and also give him an appropriate
Everything is confirmed. Whatever investigation.
Himaja, I just want you to practice in reality. I'm the patient. You counsel me. I'm the patient. You counsel me. What are my concerns and what are your concerns? And how are we going to address? Because communication between a treating physician and the patient is of utmost importance. And you have to be comprehensive in dealing all my concerns. I have a lack of sleep. I'm disturbed. I'm depressed. I'm nutritionally, weak. And I have a lot of questions in my mind. So speak to me and address my all questions.
I would explain him the nature of the disease, that the malignant nature of the disease. It is a malignant disease which requires a long course of treatment involving multiple disciplines. He first have to receive chemoradiotherapy, which may or may not give a response to his lesion. After that, we will put him on chemotherapy, during which his nutritional status may worsen. So he has to be on a properly advised nutritional optimization plan. And after the completion of the neoadjuvant therapy, we will reassess the tumor, and if the tumor does not progress or the tumor regresses and a stable disease, we will go ahead with an surgery, and which will be a curative intent surgery, and it may not be guaranteed at this point.
Whether somebody coming with an acute flare-up of ulcerative colitis and with a obstructing tumor with so much of cecal dilatation, you want to do TNT? You have seen the CT. There is a
the patient anyways requires nutritional optimization at this point of time. We will not be able to operate him right now. So we will be giving him a chemoradiotherapy, and after the radiotherapy, we have to wait for a period of 8 weeks. In that 8 weeks, we can consider him for the chemotherapy, at least for 3 to 4 cycles of neoadjuvant chemotherapy in the waiting period.
Okay. So you want to give a neoadjuvant CTRT and waiting period interval chemo, then you plan for surgery. So what do you feel that this patient will have? Already you feel there is a splenomegaly, there is a chance of early cirrhosis, portal hypertension, and your chemotherapy in case is going to have a hepatotoxicity, isn't it? Again, there will be steatohepatitis because of the chemotherapy. Do you think it's going to worsen or not? So TNT is not a condition for this case. That's why the TNT is all. This patient is CRM is negative. CRM is not positive. CRM is nil. I mean CRM is okay. We have a 3 mm, 4 mm, and tumor deposit is not there. EMI is negative. So all these conditions not against for TNT. So which patient? Only ugly patients will take for the TNT. This patient is not for TNT. That's what everybody wants to tell. So this patient, you may have to go for a surgery early as long as after the neoadjuvant CTRT. There is no difference in treating a Ca rectum with or without IBD. Same like non-IBD patient we have to treat. So as you said, neoadjuvant CTRT, you want to give a short course or long course?
Long course chemoradiotherapy, as patient have significant nodal disease and also
Okay, node positive disease, you
fat
want to give a long course, and you can, as you said, you have to explain to the patient. He may not, once you start the chemoradiotherapy, the symptoms can subside little bit, but because of the inflammatory bowel disease, the symptoms may still persist. So you have to continue some other drugs also along with the chemotherapy.
Yes.
Okay, the drugs for the IBD.
Yes.
So interval period, as said, you want to wait for 8 to 10 weeks, and you will again reassess with the MRI before going for surgery.
Yes, sir.
Okay.
Just a bit of an. This patient is not a simple patient because he is nutritionally very bad. He's hypoalbuminic, he's anemic, and he's impending obstruction. So he may not behave well with the chemotherapy and all. The nutrition, you want to give him nutrition. What nutrition you will give him? There is not going to be a blood change. Obviously, we'll give him a high protein, enteric, non-residual diet. Okay, you don't want to give a high residual diet in this patient. You want to give a high protein, low residual diet, and he may also require a TPN because he's if you look at his sodium is 132, which is very alarming. Normal patients with a bit of a upside down and all. So he's not in a very good condition to withstand a very aggressive chemo RT upfront. So that thing has to be kept in mind. It's been a close follow-up with the surgeon. He may go into obstruction. He may go into flare. Chemotherapy in a patient with an active disease, it's not a simple forward decision. It's not a simple decision. They may have to modulate the chemotherapy doses and all. So that should be in our mind. Okay, we have to give him some analgesics. He's having tenesmus. He's having a frequency of stools. His night is disturbed. His sleep is disturbed. We may have to give him some antidepressants. He has to see the nutrition dietitian to see to optimize his nutrition. We may even have to consider TPN for this patient. Okay, so that all is a comprehensive approach towards the patient. You have to counsel him in that scenario. Now, okay, we have done a chemo RT, and you want to. We just quickly try to sum it up. You done a chemo RT. He tolerated well. His obstruction was relieved. The tumor growth regressed. Do you want to reassess something else? Another before you contemplate for a surgery? You want to again do an MRI? See, let me say you straight now because we're running out of time.
Yeah.
Previous, I would like to see the staging, sir, and also a colonoscopy for the inflammatory bowel disease. If the lesion is, if it shows a response and the scope is passable.
Okay, so your CT and your CT did not show any other significant large polyps or tumors in other parts of colon, which was done. Now, you may do a colonoscopy before. What surgery? Let's come to the surgery now. What is in your mind? What surgery you are planning in this patient?
The further, what surgery?
After the neoadjuvant is done, you
I
want
did
to
not
take him
get
for
the question.
surgery or no? No, after
Yes,
the
sir.
neoadjuvant
After
is
the
finished,
neoadjuvant,
repeat MRI shows a. Yeah.
Yes, I would like
So
to
do we
consult
have
the
a
surgery
repeat
after
MRI after neoadjuvant CT in this space? Yes.
Do we have
Post
that? Okay, there's
neoadjuvant.
a.
Just
Sorry.
read this. Yes. Read this. We can go to the conclusion.
evidence of long segment heterogeneous T2 mild hyperintense circumferential mural thickening in the mid and distal rectum with minimal submucosal mucinous changes and sheet-like diffusion restriction. Longitudinal extent is ST to S5. Lower extent is 3 centimeter from anorectal junction and upper extent is 10 centimeter from anorectal junction. Extramural spread is there at S2 level with infiltration or speculations extending into peritoneal deflection. CRM not involved. EMVI is negative. No involvement of pubertals or any sphincter complex. Mesorectal nodes, few 4 to 5 suspicious nodes, largest at 7 o'clock position at S2, measuring 6 mm. Other lymph nodes are not significant. No, compared to previous MRI, no to mild reduction in size and extent of tumor noted. MR tumor regression grade is 4.
Okay, so what will you do now? So here is the patient post neoadjuvant surgery with the mild regression of the tumor and no EMV you have like 3 centimeters from anorectal junction. So what is your surgical plan for this patient?
Since the patient, disease has not regressed much, I would like to consider again metastatic workup. By reading out the metastasis, then I can check for surgery. In this patient, because the lesion is up to 3 centimeter, I would
So
like
you
to
want to
see
do
the
a, okay, you want
antitone
to do
again.
you want to do a metastatic workup. You have already done, no? So CT scan, abdomen, chest, you
This
have
lesion
done.
has not, it has not shown any response to chemotherapy. So there is a
No,
chance
it
of
has shown response, mild response, mild to
mild
moderate response.
Yes. Okay.
So once patient started with the radiotherapy, patient will relief of symptoms because the tumor will regress in size, so you'll have symptom less or less symptoms. Okay, you want to do PET CT? Any PET CT is there? Please let me know. Yeah, PET CT is there. Okay, just read. So there is no.
Enhancing perirectal and T-sacral lymph nodes. Mild to moderate ascites is noted, sir. Wall thickening is seen pyloric anterostomach with FDG with mucosal enhancements, probably inflammatory, and also a fat density lesion in the bilateral adrenal glands, and liver shows heterogeneous parenchyma attenuation, surface nodularity with volume leaf distribution, features of a chronic liver disease, increased uptake in spleen, and other is normal.
Okay, so it is since it is a mucinous tumor, you will not have a FTG update. That is one drawback in this case.
Yes, sir.
Okay. So now what is now we have there is no metastasis anywhere. So what surgery you want to plan?
Hold on.
This lesion is at 3
Any other
centimeter from
investigation you
anal
want to
now
do
compared to
on
the 5 centimeter in the previous MRI. I would like to.
Himaja,
Any
Yes,
other
sir.
investigation?
can you hear me? Any other investigation you want to do in this patient? Only PET CTs were concerned. I would like to do a CBC. I would like to see what is his hemoglobin now. He was anemic.
Yes.
Have we given any iron therapy? Did he respond to that? He has a moderate ascites in the abdomen now. For God's sake, what are we looking at?
Yes.
You're looking at a surgery. So try to optimize this patient. Look at the albumin level again. Look at the liver function test
Yes.
again. You have given a chemotherapy on a patient where we have a concern about the liver. Is his liver okay? Is LFT okay? So look at the ALT, AST, look at the bilirubin, look at the albumin. He has now ascites, which is worsened. So probably our nutrition part, we are not able to optimize this patient's nutrition, right? So we're dealing with a very high risk patient. Okay, you cannot ignore ascites like, okay, there's an ascites, I will take it out. It may be a malignant ascites also, right? But in this patient, I feel like it's mostly a nutritional ascites, but we need to keep it in mind that we are dealing with a very high risk patient. You just cannot take your guns and start saying, I will operate this patient. It is going to be a very challenging post-op period in this patient, right? So you have to be, that has to be in your mind. We need to know that what is happening on the nutritional front, what happened to his hemoglobin and all that. Okay, now let us presume that his hernia, I don't know whether we have a CBC, a repeat CBC, a repeat counts and repeat LFT. We don't whether no they're there or not.
No, sir, we don't have recent ones now.
Okay, so if we don't have
patient
them, let us
clinically improved after the new CT. Yes, I think okay. So patient has improved. His hemoglobin is like 9.5, and albumin is like 2.8 or 3. His electrolyte is okay. Otherwise, patient is okay. Platelet is okay. So his anesthetist has given fitness for surgery.
Yes, sir. So in that, I would like to.
So your voice is breaking.
And ileostomy in this patient. I would
No,
like
your voice
to
is breaking.
see a sphincter symmetry.
You can stop your video. I think your network is an issue. Your voice is breaking.
You stop your video and go on the audio alone.
Is it okay now, sir? Am I audible?
Yeah. Yes, audible. You stop.
In view of the lesion,
again, we can't hear you properly.
Is it audible now, sir?
Yes, stop.
Yes. I would like to see a sphincter from again, manometric. MRI sphincter looks uninvolved
No,
in
no.
a 3
We
centimeter.
could not hear properly.
No, but
Hello?
I think some issue with the network, sir. Hello, sir.
Yeah. But
Hello.
I could not hear. We could not hear you.
Hello, sir.
Issues with the network are the same as the issues with this patient.
I'm sorry for the network, sir. I'm trying to.
Oh,
be-
now we can hear you. Yes, talk.
So, in this patient, since the lesion is 3 centimeter, I would like to check the anal sphincter tone again and anal manometry, and it is less likely to be a patient will require total proctocolectomy. Is, appears to be difficult in the lower extent of the disease, sir. It is at 3 centimeter from anal verge.
Hello? No, we could not hear you.
Is it audible now, sir?
Yes.
Yes, sir. In this patient, because the lesion is 3 centimeter, I would like to see the anal tone and manometry again. And
Okay,
if
anal
they're
tone manometry is normal.
so if they're satisfactory and if patient is counseled about the chance, I'll counsel the patient about the risk of fecal incontinence after the surgery. If the patient is building for it, I will go for an
Why
total
fecal incontinence
proctocolectomy.
should have patient after
If
surgery?
it is 3 centimeter, we may
Why
require
you
doing
want
an
it but fecal incontinence? We are going to damage a sphincter while doing surgery. Another important thing, you want to know whether there is a fistula, low fistula is there. I will do a transrectal ultrasound to make sure the fistula is simple fistula. There is no communication of the fistula to the lesion. That is very important. That will decide the what type of surgery. If the fistula is not communicated to the lesion and the sphincter is good, for this case, young fellow will go for a total proctocolectomy with the ideal pouch anastomosis with the diversion. So still, once
Yes.
you do that, once the patient regain his back, his whole nutrition and all the things, protein is improved and anemia is improved, then we go for a ileostomy reversion. Okay.
Yes, sir.
Okay.
Raj Pandya, I think I will have a difference of opinion.
Yes.
I will do a total proctocolectomy with antileostomy with such a low rectal cancer post-radiation patient. Because I'm not comfortable doing a pouch in this patient.
Well, I will have a different strategy, discuss with the patient. Imagine the
Yes.
patient's consent is very important. It's basically not what we feel. It's his decision, and we help him to
Yes.
reach to decision. That has to be understood. It's not we the gods on the earth. So I would counsel this patient that he has a disease which is very low lying and is a cancer. Normally, these patients go for a pouch, where we will explain him the frequency of the motions he will have. Initially, some patients have even 7, 8 motions, will be depressed, so we have to counsel him. In this particular patient, because of his moderate ascites in abdomen, I'll be skeptical in doing a pouch upfront. I may go with a total proctocolectomy, save his lower distant rectum, see the margins are okay, because he has already received a radiotherapy. I would go on an ileostomy, improve his nutrition. I would not guarantee him that I will do a pouch, but I may attempt in future a pouch reconstruction if feasible. But
Yes,
with
sir.
a moderate ascites, I will also like to not to go with a straight away with the pouch in this patient. That would be my, but that will be my suggestion to the patient. Ultimately, some patients may say, we don't want a pouch, just give me a ileostomy, I'm okay. And some patients say, "Sir, do something, sir. I'm okay to go for another operation in future, even if it is not possible. But I would like to see a pouch I would like to be a continent patient. So patient has to be taken into consideration. His decision has to be respected. Okay.
Yes, sir.
Okay.
Yes.
As there is difference of opinion from the faculties, anyway, that depends upon the patient. If the patient accepted, okay, but depends upon the condition. But in this patient, definitely the sphincter function is the criteria before going for the pouch, and the fistula is low lying and should not have a communication for the lesion. But since the patient is having like a T3, probably N1 disease, post neoadjuvant radiotherapy, if there's a good response, young patient, sphincter function is good, definitely I will offer a pouch for this patient. Even if the pouch doesn't function, later the patient can be converted to permanent ileostomy rather than first time we have a permanent ileostomy. That is my option for this patient.
Okay, that is debatable, Himanshu. So, how are the tumors developing in ulcerative colitis different from a sporadic colorectal cancers? Just a final, I think.
If it is compared stage by stage, it is of same prognosis as the sporadic cancers. But
So
there are more of mucinous adenocarcinomas than.
Yes, number one, they are more mucin secreting and more component of signet ring tumors. Number two,
They present lately because of overlap of symptoms, but once diagnosed, if the stage is by stage for matching, it will have same prognosis as a sporadic cancer.
yes, if they are delayed diagnosis. Anything else?
The post-operative complications.
In terms of genetic markers, mutations in this. They have low rate of APC mutation and KRAS mutation, and there are more through the WNT pathway. So that is another difference compared to the sporadic cancers.
Okay.
Okay, I think we are done.
Okay.
You did very well. It was a good presentation overall. Just be patient-centric, be confident. When you are asked what will you do, you will, just think what you're doing in your OPD. Don't be, there's a bit of a hangover with this networking and all. Overall, it was good.
So I think we have comments from the other experts also, Dr. T.D. Yadav and Dr. Shastri. So you can read them out, I think. Dr. Pradeep, you are here?
So Pradeep sir is out of station, sir. We can invent some other faculty.
Yeah.
Yadav sir.
Dr. V.K. Kapoor is there, Dr. T.D. Yadav is there. We'll have their opinion.
Morning. I think Dr. Shastri wants to say something,
Yes,
maybe after that.
Yes.
Just brief. I put my thoughts in the chat box also. The first general thing is, Himaja, you have a habit of speaking very fast, which sometimes may sound a little, impulsive. Practice speaking in slow and measured tones. That will give you a lot of confidence. Second is, when you're asked about treatment, particularly in this type of situation where there are multiple factors to be considered, you give treatment options and develop an argument. And ultimately, it will be a shared decision between you, the other tumor board, and the patient and attendants. It's important not to have a single opinion about this. That other than that, of course, other things are already mentioned. Say colonoscopy is the first investigation when you have an obstructing problem there, and the patient is not a very good general health. And then saying normal bowel loops on CT as an impulsive first observation when a dilated colon is staring at you. You should have corrected yourself immediately. It's not unusual to make a comment, but you should correct yourself immediately. Apart from that, I think you have done by and large quite satisfactorily.
Thank you, sir.
Morning. Good morning. This is V.K. Kapoor here. So a few points for all the students. Many a time you have a long history of a benign condition and then a short history suggesting a change. For example, GERD, gallstones, choledochal cyst, chronic pancreatitis, FAP, ulcerative colitis. Now, if you start with 6 months history, many examiners stop you after the presenting complaints and ask you what are you thinking? And then you will come back and say, no, sir, this patient has a 10-year history also. So I am personally of the opinion that if the so-called past history is related to the present history, it should become part of the presenting complaint. That is one. Same happens in patients who have a cholecystectomy and bile duct injury. Many students start talking of the bile duct injury and then say that the patient has had a cholecystectomy. That probably is not correct. Now, after the history, you made a straightaway diagnosis of ulcerative colitis. I think you should have said inflammatory bowel disease, most likely ulcerative colitis. Many students use this phrase in abdominal examination, no other lump palpable. No other lump means that there is a lump which you have palpated and there is no other lump. If there is no lump, you should say no lump palpable. There is a difference between no lump palpable and no other lump palpable. Fistula in ano, after 2 or 3 questions, you came to proctoscopy. That is not correct. Fistula in ano, proctoscopy has to be done in the first instance only. You can't. So when an examiner questions you, instead of saying no, but this is so, you should say yes, but this is so. You should first agree to the examiner and then give your explanation. That's a very diplomatic way. I think you should have analyzed the present history of about 10 motions per day as a manifestation of acute exacerbation or as a manifestation of a large rectal growth, which itself can cause spurious diarrhea. So you should have been a little more analytical in that. By and large, GI malignancies are not hard. You described this as a hard growth. They are usually firm. You used a word that CRM is patent. CRM is not patent. CRM is not involved, threatened, or involved. Patent is not the correct term. Now, in the management of this case, at both the stages, you did not give enough emphasis to nutrition, which is a very, very important part of management, especially in a case like this, who is obviously nutritionally depleted, who is malnourished. And in fact, I would like the experts to comment on this. I personally would very seriously and strongly consider a proximal diverting ileostomy before starting any treatment for this case, because I feel that that's the only way that I can improve the nutrition of this patient. Maybe the others can opine. And just a last announcement, students, please send me a mail, dkkapoor.india@gmail.com. Write UC in the subject of the mail. And a request to all the faculty colleagues, the Jaipur Surgical Festival will this year be held from 6 to 8 December, Friday to Sunday. Theme is complications in surgery. Although I have posted the request on the GIS faculty side, but if any of you would be interested to come as a faculty, please contact me directly. Thank you.
Yes, sir.
So Shiraz, Amanjeet, and Dr. Raj Pandian, your opinion about ileostomy?
I agree, Dr. Kapoor. I think even I was thinking of doing a diversion, but also it was low, so otherwise we could have planned for a stent. Because these patients with ulcerative colitis, they don't tolerate chemoradiation so easily. It's very difficult for a obstructed patient with acute flare-up to receive neoadjuvant chemoradiation. So I'll have reservation on starting upfront. But since the case was already written, so I'm not objected to that.
Sir, I have a little concern in doing an ileostomy in this patient because he was having a symptoms of closed loop obstruction, which may not be relieved by ileostomy alone. I agree that after a neoadjuvant protocol, if his nutrition is not improving and his closed loop obstruction has got relieved, definitely ileostomy would be my an option. But with a closed loop obstruction, ileostomy probably will not relieve us unless there is a relief in the distal obstruction.
So I also don't agree for ileostomy, sir, because I'm planning for a pouch for this case. This is the case. Unless you remove the diseased part, the patient will not improve. So what I feel is what the experience. Probably this patient after neoadjuvant CPRT is a young fellow with a good response for the radiotherapy. Once you start giving radiotherapy, the tumor will shrink and he will have the relief of obstruction will be there, which will evident. And of course, the nutrient path will not be fully relieved. So we should give, as you said, sometimes we may have to give definitely with the blood and with the albumin or the TPN before going for a surgery, getting anesthesia fitness. Once the anesthesia is given fitness, definitely this is a case I will do for a first time total proctology with the pouch, because once you do a end ileostomy, definitely you can't do a pouch later. Patient will be there with the end ileostomy. I will do a pouch and with the diverse ileostomy, and definitely the patient will improve for another 2 to 3 months. He will put on weight. Once he improves the weight, then he will go for ileostomy reversal, and you will have a good life post-operative. Definitely.
Raj Pandian, I think as a traditional teaching, I think we are teaching people
Yeah,
that
but for the exam, yes,
low
the exam,
rectal
all
cancer
the we can have,
is
yeah.
contraindicated. So,
Good morning, Dr. Aman. Hello. Hello.
yes,
Dr. Aman TD Rather here.
Yes,
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 yes.
yes, sir.
Yes, I just want to comment about doing a pouch in this patient. You know, the tumor, as I was hearing, is about 3 to 4 centimeters from the anal wall. And this is a adenocarcinoma, which is mucin secreting. So getting by traditional teaching, you should get a margin of about not 1 centimeter margin is going to work. So ideally, it should have 3 to 4 centimeters of the margin. That would be one very big concern. Second is that what about the recurrences, local? And third would be the sometimes these tumors have a very poor tendency to recur systematically. And especially when in pelvis recurrence occur, pouch becomes very difficult to manage. So that would be the major concern. And ileostomy also is not a very worst thing, and pouch is also not a panacea. So I think we have to weigh. And a colonic diversion, I was thinking in the first go that diversion of the colon and then waiting for something, because there is a free fluid, there is a tenesmus, patient is having multiple painful stools. So all these things have made the life of the patient very terrible. So doing a diversion and preparing the patient, then going ahead with whatever option would have been better. This is my opinion. Thank you.
Yes, Dr. Yadav, I agree with that thing. We might be doing some things because we might be, Dr. Raj Pandian might be a good surgeon, but as a traditional teaching to the students, we advise them not to do a pouch in a tumor which is at 3 centimeters from anal wall, especially in a radiator patient. Dr. Shiraz, yeah.
Well, I think technically speaking, if it's not about technique whether we can do it upfront or not. My concern is the nutritional status with a moderate ascites in abdomen. I will not be very keen on doing a upfront pouch, and that later on pouches have been well described. But yes, you need to. It will be challenging surgery. It's not impossible. We have done it. It is possible. It is written in the literature, and all matters is the surgeon comfort level. I don't think we should carry on either's baggages, whatever we are comfortable with, and what the patient agrees on with our plan. If he is insisting on something else which we don't have in our armamentarium, I'll be happy to refer it to someone else who does it probably in a better way or follows his pathway. I won't be strict on my plan. It all varies from person to person and patient to patient. But I'll be doing what I'm comfortable with, and if my patient agrees to stay with my plan, I'll be happy to do this. And we shouldn't be doing something which is not documented or written in literature. There's plenty of literature about early versus delayed pouches being done in cancer rectums. Recurrence, yes, of course. The people who argue for pouch upfront or delayed, they say doesn't make difference a pouch with a recurrence or pouch without a recurrence. The incidence is same. The patient goes back to the ileostomy. So they argue that if he doesn't recur, he has a pouch. If he recurs back, he's on an ileostomy, which he would be otherwise also on ileostomy. So that is the argument the people put forward who favor pouch in a Ca rectum with the neoadjuvant radiotherapy given before. The only concern is you can't give radiotherapy after the pouch creation. So it is all debatable. Yeah.
Yes. And
Okay,
Himanshu,
you
don't
will
perform the
accept,
TI.
Yeah. For exam point of view, you will not be penalized whether you say pouch or without pouch. So you are safe. You
Yes.
can see many people not, in favor of pouch. But as Dr. T.D. Yadav told, the distal, margin, if you see a frozen section is negative, you can do. So probably the experience will talk. So even the frozen section negative you can have, but only thing is for pouch, for making a pouch, in this case post MRI, you said there is 3 centimeters from the anorectal ring. Anorectal ring is above, not from the anoveg. That means the tumor is well above, so you can offer, but you are not penalized. You will not be penalized for not saying the pouch. So, but only thing in my point of view, you can give a chance if the patient pouch if you have a recurrence, anytime we can go for a APR permanent ileostomy. But if you give a once permanent ileostomy, probably you can't go back and do a pouch. That is the only concern because it depends upon the experience of the each consultant. Okay.
So if last comment, if I had to assess you as a surgeon, as a young budding surgeon, I won't fail you or assess you whether you are doing a pouch or not.
Good, no
I would assess you whether you concern the patient, you're giving him a relief, you're concerning his nutrition, his depression, his antipsychotic medications, antidepressant medications, you're concerned about his MDT case presentations. That is what is more important at your level. Whether you do a pouch or you don't pouch, you're not going to fail, or you're not become a bad surgeon or a good surgeon. Your comprehensive approach is very important. Okay.
Can we know what has happened to this patient? What surgery was done? Any idea?
Sir, initially the neoadjuvant part was given outside, and the patient could not tolerate actually short course radiotherapy. So at that time, he came to us with an acute flare. So we ended up performing subtotal colectomy, but we couldn't get a margin, and total proctocolectomy with APR and endomestomy was done.
Okay. So patient notwithstanding, so they have done. So once you get rid of the lesion, patient will become normal. Okay. Okay, thank you. You have done good.
Pradeep, sir, your last comment, final comments,
Dr.
closing
Pradeep
comments.
is there? No, he said he is out of station. Somebody told.
Okay.
Dr. Pradeep is not there. So with this,
So
thank you very much. And thank you, the other moderators also. Bye.
Thank you very much. Thank you.
Bye.